So, good morning, everyone, and welcome to this lunch symposium. And I think we quite a bit of late for the time, and we also have the tight schedule after this. So I would like to start now. And this is lunch symposium is about the TAVI. As we know that the advanced technology treatment for the cardiac surgery have shifted from open to minimal invasive and also to the transcatheter treatment. TAVI is one of the promising technology that used nowadays. But we also that TAVI not always safe 100%. There's still some complication, and which include like stroke or LV rupture or coronary problem. And today we have two distinguished speakers. One is the cardiac surgeon, and one is cardiologist, intervention cardiologist, which is we'll have the two topics for this symposium. One is about the cerebral routine use of cerebral protection device in TAVI and beyond, because we know that TAVI also have the risk for stroke, even though it's low, but we should like to have the patient to be safe. And this topic will present by Dr. Daniel Chan. May I introduce him a bit? He is a cardiac surgeon from Queen Mary Hospital, Hong Kong. He is very skillful in minimal invasive robotic surgery, and he is have the training fellowship in East Carolina University, USA, and now he is a director of heart team at Queen's Mary Hospital. Okay, so I would like to, Dr. Chan, please.
Topic with you. Okay. So my topic is about the use of a routine use of the cerebral protection device. So these are my disclosures. Now, first of all, TAVI. Even as being a surgeon, one thing I cannot deny is that the prevalence, the use of a TAVI is going up exponentially over the years, especially 2 years ago, when FDA approved to use in the intermediate risk patients. Last year, FDA approved to use in the low risk patient. Well, the numbers keeps going up. And some cardiologists will say that by 5 years later on, 75% of the aortic stenotic patients will be treated by TAVI. Well, I'm not totally agree with that, but you can expect the numbers still going up and up. Although TAVI is the most minimally invasive option for treating AS, but still have complications. These are some of the major concerns we're talking about. Now, if we take a look on the registry or trials, these numbers are arbitrary. Like 8 years ago, the numbers like that, all right? But over years, of course, there's some improvement. Now, the mortality is less than 1%. Major complication will way below 5%. Mainly because we have smaller device, okay? Now the French like 14, 16, so vascular complications way less. Newer generation of device targeting of less paravalvular leak, also increase in the experience, including those better patients, so our mortality and also paravalvular leak is way less. But if you see about the complication of stroke, that's not much change over years. This is one of the registry from Germany. So they reviewed the 7 years changes of the outcome of TAVI. You see over 7 years, the not much change in the stroke risk. And if you see the TAVI results on some meta-analysis in 2012 compared to those in 2016, and take a look on the number of recent trials, most of the numbers are quite similar. So for stroke per se, it's still about 4-5% overall TAVI outcome, not much improvement over the years. Unfortunately, when a center doing more TAVI, when they have more experience, doesn't mean that they can escape the chance of having stroke. So this is the TVT registry. if you look at the more than 40,000 patients in the DVT registry, they find out that TAVI experience is actually associated with a better in-hospital mortality, vascular complication and bleeding, but not stroke risk. So no matter how much you do, you cannot escape stroke. Cause of stroke in TAVI, simple. More than 95%, I would say, is due to emboli. The emboli coming out from the plug on the aorta or from the valve, because most of them is AS, so they have a calcified, a lot of debris were coming out. Also, there might be blood clots, or even the TAVI valve material, or even some may have the muscles or vascular tissue coming out as the emboli. So stroke per se, if personally as a clinician, I would say is the worst complication among all. First of all, it's only we can offer supportive treatment. When we consult the neurologist or neurosurgeon for some emergency embolectomy, usually the answer is too late. Okay? After the procedures, you pass the golden period, too late. So just supportive. Unpredictable recovery. And you know that the TAVI group of patients is elderly. Okay? And everybody knows that once you're older, the potential of recovery is less. They usually stay long in the hospital, and then there will be more complications like infection, bad sore, and they cause some economic burden. And also, as a reminder to you, every day you do the rod run, you say, okay, that's a failure of your case. Okay, every day, just a reminder to you have a failure. And no need to say they cause a higher mortality as well. So this is a meta-analysis recently in 2006. When comparing those patients after TAVI have stroke, they almost have a 4 times higher mortality compared to those patients without stroke. So now, overall, these are the list for those registry or trials mentioning about the stroke risk. So you can see, basically, ranging from 1.4% to as high as like 9.1%. So the reason behind is that most of the trials or registry, they use a clinical criteria. If the patient can eat, can move, can go home, no stroke. But you see the trial from Sentinel, so they use a neurologist assessment, including some higher function. That's why the definition makes more patients categorized as having a stroke after the procedures. And if you use some imaging to document, so this is a study using a transcranial Doppler. The patients will wear this device to see how many ultrasound evidence of emboli going to the brain. And they see that during the whole TAVI procedures, there's a lot of a signal going on, especially during the deployment of the valve. And some studies use very detailed MRI assessment of the brain after procedures. And you can see they found more than 70% of the patients have brain lesions, which can be detected by the MRI, but they don't have any clinical implication yet. So stroke in TAVI basically is the iceberg theory. Now, we are just seeing the tip of the iceberg, which means that whether the patients have a disabling stroke, TIA, or non-disabling stroke. Okay? So I think for clinician, we will be quite happy for that. But if we use like the neurologist criteria, there is a lot of a neurocognitive decline among those patients. And even more, if we use the MRI to assess all our patients, there's a lot of a silent infarct after TAVI. So this is just like an iceberg. And we don't know yet whether this group of a silent infarct, how they can affect our patients. Especially, this worries me. When the TAVI moves towards the younger, fitter group of the patient. So we take a look at another aspect, is the timing of the stroke. Now for all the registry or the trial, they document that more than 80% of the stroke happened early after the TAVI. So we call that the peri-procedural stroke or the stroke within 72 hours. Now, we come up all the things stroke after TAVI. First of all, it has a major impact on the results. It has a major impact on the mortality. The stroke rate was quite static over years, around 4%. And more than 95% of the stroke is due to emboli, and more than 80% of the stroke is peri-procedural. that is the idea why we drift to having an idea of a cerebral protection during the procedures. Try to take out the key risk of the patient having a stroke. Now, there's two big group of device available. One is a filter and a capture. The second one is a deflection, so just to direct all the emboli towards somewhere else, but not the brain. Now, this is a simple table comparing the available devices. So since you already sit here, you know which device I'm going to talk more. Now, this is the most common use and also the first FDA-approved device, the Sentinel device. The idea is that there is the two filter or two basket. So one of them will put in the innominate artery or the brachiocephalic artery. Another one will put in the left common carotid artery. So the key idea is to filter more than 90% of the blood going to the brain. The only unprotected artery will be the left vertebral artery, which comes out from the left subclavian artery. Now, I don't want to go into details of the data, but just some highlights from the Keystone trial from the Sentinel trial. Now, from this trial, they stratified more than 300 patients to test group or the control group. First of all, this device is very safe. You can see the related complications is 0.4% only. But you see the clinical result like the stroke, like the MRI detectable brain lesions, it cannot reach statistical significance, although there's the trend of less disabling stroke or emboli in the device group. Second thing is that there is a high rate of a capture rate, like 99%. So it proves that there is a lot of emboli during TAVI, okay? And most of the emboli is quite in a big particle. This is some example that can be captured by the device. And number three is that it is the first study shows that there is some correlation between the new MRI lesions with the neurocognitive function. Okay, so there is the worry is correct. So there is some subclinical impact to the patients if they have new brain lesions. Now, we'll skip most of the results, but this is a take-home message. So when we pull up all the data and have a collaborative analysis, like more than 1,000 patients, the perioperative stroke will be reduced by 65% by using of the Sentinel device. And this number is true in other real-world single center experience. So you see most of the center will quote like 70% or even higher of a relative risk reduction for stroke. And this is another meta-analysis. So this includes 5 other randomized control trials, not only Sentinel. So overall conclusion is that all-cause mortality and stroke at 30 days is lower in patients using cerebral protective device. Okay, so the idea from the data itself, it speaks for the cerebral protection device. No matter which kind of device, if you have a patient going to do that, use it, and most likely you would reduce the stroke risk by 65%. Now, I'm not going to share you much more on the data, so I'll try to share you some real case or some personal opinion by using routine cerebral protection during TAVI. So this is our numbers in our hospital. We start to use the cerebral protection device in the mid-2017. Up to last year, we've total implant 106 cerebral device during TAVI, is about 80% of the case. So together with the pre-Sentinel period of the patient, there is a patients of 106 with the device compared to 164 without the device. So just a summary of our results, just like other trials, just like other data, all the clinical results doesn't reach this statistically significant level. But since our use of a Sentinel, we haven't seen a patient with a clinical stroke. But touch wood, lucky to say that our patients, even without Sentinel, the stroke risk is not that high. Now, my sharing is that about when you try to use the cerebral protection like a regular basis, like try to use it in all patients. Okay. Now, in that case, we take a look on the patient without using. First of all, we have 29 patients. 19 patients of them I'm not using because of financial issue because it's not reimbursed, so the patient have to pay for themselves. Okay, but there are 6 patients before the operation we plan not to use because of the CT. 4 of them we abandon the procedures because the device cannot go up, and 3 of them we can only open up 1 filter. So this group, I would say, this kind of a failure. Now, first of all, as recommended by the company as well, we need to see the CT and also the aortogram to see the arch anatomy, the size of the bacteriocephalic artery, and also the carotid artery. They have limitations. If it's too big, too small, you cannot put in. And also, I will add one thing is that there is a significant osteo lesion. Because if you can see that from the CT or aortogram, I would think the pure manipulation of the device may cause emboli or may cause even further obstruction of the branches. Now, talking about arch anatomy, as we will see, a surgeon will see a lot of a different anatomy. This is a classical description, well, more than 10 type of a variation of the anatomy. But for me, simply speaking, I will say 3 types. One is the normal type. So, normal anatomy, brachiocephalic, left common carotid, left subclavian, normal. Luckily, more than 70% of our patients is the normal type. Second is still 3 branches from the arch, okay? But we can call them bovine arch. So the brachiocephalic and the left common carotid artery come from common origin. But still you can see just 3 branches from the arch. What you have to be careful is that you see 4 branches from the CT or aortogram. Because upon the 4 branches, there are some you can do and some you cannot. So my idea is that if you see 3 branches, okay, just go ahead. Okay, like more than 99%, you can put in the Sentinel device. But you see 4 branches, be careful and look carefully. Okay, I will explain why. Because of the bad experience, right? So just to recap that, I have 6 patients, about 5% of them we already excluded from the Sentinel protection. Second thing is the radial artery challenge. Now, for surgeon, our experience is taking out the radial artery for CABG. But I asked my cardiologist colleagues, they said, well, they routinely use the radial artery for the PCI stuff, okay? They also told me after using Sentinel, they, well, unexpectedly, a lot of radial artery challenges, okay? Now, first of all, is radial artery loop. So this it is more common in elderly patients, I would say. Whether you can see the little angiogram here showing the radial artery loop. So we don't routinely do that. But this case, because even the guide wire cannot go up to the arch, so that's why we just do an angiogram and find a big loop over here. And the next one, that's we are using a Terumo wire to cross that big loop. And finally, we can successfully exchange to a stiffer wire to straighten up the loop, and then we can go in with the device. So second radial artery challenge is the accessory radial artery. Okay, so this patient, we have the wire already in the arch, but the device cannot go up. We got stuck. So that's why we do an angiogram. And actually, the angiogram shows that the wire is not in the radial artery. Okay, it just goes through the radial accessory artery into the arch. Okay, so we need to repuncture, reposition of the wire before we can go up with the device, okay? Because most of the time, just like this example, the accessory artery is very small, okay? Your wire can go, but not the device. Okay, so out of our expectation, radial artery challenge is more common than we expected. So in the past, actually, we just go up with a 0.014 wire, and then we will go in with the device, all right? But now, we will take one more step. We usually will go up with a regular wire first. Because try to avoid the injury to the radial loop or to the accessory artery. So all 4 patients is that we don't know there is a challenge. We just go in with the device and causing some hematoma over the arm. So we have no choice. We have to abandon. So if even the wire cannot straighten up or cannot arrive the arch because of the radial problem, then we will use an ultrasound-guided brachial artery. But we don't like that because for brachial artery, we are afraid there's more complications, and also you have to stop the bleeding by your hand, right? So after the wire going to the aortic arch, we like to have a little loop at the aortic root. So this is just a regular thing. Okay, just start to deploy the first proximal filter by pulling the number 1, and then we will turn the number 2 and cannulate the left common carotid artery, and finally to put in the number 3. So it's easier and quicker if you have an assistant know how to do it. So usually, if in a regular anatomy by putting the device by the 2 operators, usually we can do that less than 2 minutes. But sometimes we have unexpected arch anatomy. So this one, I will admit that's my fault. So we have looked at the CT. Oh, looks like 3 branches. Okay. And then we do an angiogram. Looks like 3 branches. All right. Let's go ahead. But interestingly, the device comes from the distal arch. So it's actually 4 branches, but we miss out from the CT and also from the aortogram. So it's actually a abnormalous right the subclavian artery going to the distal arch. But since the device is already in the arch, and so don't waste it, we just cannulate the left common carotid artery and deploy 1 basket. All right. So together with this patient, we have 3 patients in total have an unexpected arch. So that's why I would say that if you see 4 branches from the arch, look carefully. If not, just 3 branches from the arch, you can go ahead without any problem. So I would say this is not a total device successful. Defeat the purpose of 2 baskets. So 1 basket I would still see is a device failure. In our experience, the capture rate is not that high. Just around half of them have something captured by our bare eyes. Maybe I have some, bad eyes, so I don't see much from the capture. At least there's no added major complications. There are a couple of patients have some arm hematoma, but they are self-limiting and heal by themselves. So deployment time usually is like 2 to 3 minutes if in a normal anatomy, but it takes like more than half an hour, even longer than the TAVI procedures per se, if we met some challenging anatomy. The learning curve is quite short. So now we have 2 surgeons, including me, and also 4 cardiologists can independently deploy this device. So all of us need about 5 cases of guidance, and then we can be independent. So I would say if I use the routine cerebral protection in TAVI patients, the overall success rate will be around 90%. So this is the slide from the company. The numbers are a bit different, but I would say this is true only in selected patients. So if you plan to use it routinely, I would say the success rate will be a little bit lower, about 90%. The deployment times a bit longer because you take more precautions to avoid the challenging anatomy. But at the end, it's still a safe and quite an easy procedure to perform. Now, having achieved the routine use of cerebral protection in TAVI, so we try to use it in other areas. One is that because we're surgeons, so we try to see whether it can be used in open heart surgery. Number 1 is that actually aortic, open heart surgery or surgical AVR has a higher risk of stroke compared to TAVI. So this is a recent meta-analysis in 2019. So overall risk rate, the stroke risk rate is about 2.2%. And if you see the latest trial from the partner-free and also the Medtronic low-risk trial, the surgical arm has a higher stroke risk, is still ranging from 2.5 to 3%. So it's logical to think that cerebral protections, are they more useful in open heart surgery patients? So this is not a new idea. This randomized control study published in 2017. So there are 383 surgical AVR patients stratified into 3 groups. First is a suction-based cerebral protection device. So they have a suction over the aortic cannula at the back of the aortic cannula. So all the blood, not all, but most of the blood going to this area will suck back to the cardiopulmonary bypass machine and then go back. So another group will be in the intra-aortic filtration device. So it's an extra device, have a basket over the arch, so it's sort of like a filtration. So, and the third group with the regular cannulation group. Now, first of all, from this trial, the capture rate is quite high. These are some of the example. 75% of the device have something captured, so it's quite high. However, just like other cerebral protection trial, the primary outcome, like clinical result and the infarct on MRI, doesn't reach the statistical significant level. But their secondary outcome, like decreasing the delirium and the infarct volume on MRI, they have significantly less in those patients with cerebral protection device. Logical, it is the reason behind is logical, because besides emboli, for open heart surgery, we have the issues from the cardiopulmonary bypass. So you have an extra emboli, you can have hypoperfusion, you can have inflammation, and you have higher intracranial bleeding. Also, we have a higher chance of a late stroke. Okay, 1/3 of them have a late stroke, which cannot be protected by the cerebral protection device. So this may be the reason why it's not so effective from the trial. So from our experience, I only have put in 4 Sentinel in open heart surgery case, but I think that we can select those high-risk patients to do that. I have put in 2 patients in they plan to do a left ventricular assist device, the LVAD patients. Especially, we see there's a LV clot, okay? Because the LVAD, we have to put in the machine at the apex, so it's logical, the manipulation causing emboli. I put in 1 in a patient with a young patient with a severe MS. So on the echo, there's quite a big LA clot. Same idea, I'm just afraid there will be emboli. I put in 1 in patients having a hybrid procedures. It's an open off cap together with a transaortic TAVI, because these patients have all sorts of calcium along the aorta, aortic root, the aortic valve, together with the coronary as well. So all 4 patients, I got something in the basket. To be honest, sorry I could not find all the pictures, but to my impression, the amount of capture is more than we got in TAVI. And for them, no early stroke, but 1 LVAD patient had a subdural hematoma 1 week later. Of course, it's not related. So, but I found out some issues when doing that in an open heart surgery. First of all, it's the place. Regularly, we don't use the hybrid theater. So what I can use is a C-arm, and the image quality is suboptimal, especially when you're using the small guide wire. You have to move very slow, otherwise you just lost track your wire and your device. And also you have to expose the femoral and the radial for the puncture. And after the device in place, you have to secure it. Because one of the 4 patients, before I planned to explant of the device, I found the arm is already dropped down from the table. And, well, nobody knows about it because it's quite a fat patient. So, but we need to find out some method to secure it to go through that longer open heart surgery. And also, we have to take it out early. Especially all of our open heart surgery, we give protamine after the procedures. I think with the protamine, there will be some clot on the cerebral protection device per se. So that might be more logistic affection rather than TAVI if you want to use this in an open heart surgery. So there are also a number of reports using this device in other endovascular procedures, like mitral clip, like the LA occluder, TIVA, and also some valve-in-valve procedures. Now, this, you can see the number of patients is very small, so they don't give you the significance of the effect. But you can take a look on the debris. Almost all of them get some debris, even in TIVA. So theoretically, when you're doing a TIVA in the post-arch, so you're doing something after the arch, so, and the blood going in that direction, you shouldn't have any stroke. But in fact, they can get something. Okay, so well, it's still underway investigation, so we may see the more data on later on. And last but not least, there are a lot of cerebral devices coming out in the market. So most of them have been done the first-in-human trial, so they are undergoing the phase 2, phase 3 clinical trial. But in the future, there are a lot of a different kind of device. The target is to protect the cerebral arches, the cerebral vessels, in order to decrease stroke in all sorts of cardiac procedures. So summary is like that. I think stroke is still remain a significant complications in TAVI or in other cardiac surgery or other endovascular treatment. Cerebral protection device, at least right now, we know that in TAVI, we can reduce 65% of a perioperative stroke. The procedure, proved by multiple trials and single center experiences, that it's safe and it's fast. The expansion of the use is very attractive and under investigation. So TAVI, as well as other cardiac procedures, when we move them to a lower risk patients, we move to the younger patients. So I think the quality improvement for the overall program is imminent. And I think it should be used regularly and in a routine basis. So thank you very much.
Thank you very much for a very excellent and informative presentation. So I just, you can prepare. And just waiting for the next speaker prepare. So I would like to ask some question that you have the experience with use the Sentinel in LVAD patients. And I just would like to know that how long that you have to put the device inside the patients in that case.
The procedure, the only for cerebral protection, it takes like 15 minutes. Just because of the image quality from the C-arm. So you have to move slow and quite difficult to see. Okay? And the whole procedure, the LVAD procedure, lasts about 2-point-something, around 3 hours. So right after everything finished, before we give the protamine, I have to take the device out. So the device actually stay in the patients around 3 hours time.
Okay, so not live that long.
Yes.
Okay, and so maybe I would like to move to the next speaker first, and then we can have some discussion after this. So the next speaker is the intervention cardiologist, Dr. Purit from Central Chest Institute, and he is young staff and rising star in Central Chest Institute. He will talk about the best practice of ACURATE neo valve central chest experience.
Okay, thank you for the kind introduction. So good afternoon, ladies and gentlemen, my colleagues. So I'm the interventional cardiologist, so I present this lecture on behalf of our CCIT TAVI team. My lecture is supported by Boston Company. This is my disclosure. Scope of my talk is about TAVI, ACURATE neo valve, use of ACURATE neo valve in small and low choric anatomy, and our case experience. So as Dr. Daniel said, about a lot of randomized trial in TAVI versus surgical AVR begin on 2002 and continue. After that, there are multiple CE mark for TAVI valves, and Symetis Neo or ACURATE neo valve begin on 2014. And TAVI is the procedure which increase immensely every year pass by. So nowadays, I think everyone know about TAVI and begin to do TAVI in the hospital. So indication for TAVI is shifting to a lower risk patient. So now we try to find any valve which cause a low complication and good valve function for long time. ESC guideline recommend TAVI as class 1 indication equal to surgical LV valve in intermediate risk patient, and I'm not sure that next year or next 2 years is begin on the low risk patient or not. TAVI in CCIT began in 2016. We perform multidisciplinary team meeting, patient selection, set up workshop, and as first 10 cases we begin with Edward Serpent, transapical 5 cases and transfemoral 5 cases. After that, we shift to ACURATE neo TAVI valve. There are several reasons in choosing this valve instead of the previous valve, which I will tell you after this. ACURATE milestone begin on 2006, and now more than 15,000 patients use this valve. So ACURATE Neo is self-expanding and supraannular valve. It has several unique designs. First is a stabilizing arc, which gives axial self-alignment and support precise valve deploy location. This is the stabilizing arc, and the upper crown to cap native leaflet and provide choric clearance. So a lot of studies show that there are almost 0% choric obstruction after immediate deploy of this valve. So stent body height is around 18 to 19 mm. Landing zone is approximately 20 mm. Due to the stent body height is quite narrow, so choric height more than 8 mm is safe to use. The artery valve size range from 21 to 27 mm. The delivery catheter is quite flexible. So first operator is just grip the delivery system, and second operator rotate knob 1 and then knob 2, and then the stent is deployed. So after we release the first knob, the stabilizing arc is released, and then the second knob to deploy the valve. Because of the stabilizing arc is we can deploy without pacing. And this valve can also use transapical also. ACURATE neo-aortic valve system have a lot of trial and ongoing RCT trial to compare with Sapien and Evolute valve. Trial is a cohort study published in JCC Intervention 2018, which enrolled 1,000 high-risk patients with CVAS in 25 EU centers and looked at the all-cause mortality at 30 days. Secondary endpoints are procedural success, device performance at 7 days and 12 months, including safety and other significant clinical outcomes. Median age is around 81 years old, and STS score arrived at 6, which is intermediate. P-titration is performed almost all patients. Post-dilate is 44%. This valve usually no need to deploy while rapid pacing, as I told before. Only 48% patients deploy while on rapid pacing. Mean aortic gradient decreased significantly to allow average age, and all-cause mortality at 30 days is only 1.4%. Procedural success post-implant is around 98.7%. For the safety endpoint, the stroke rate at 1 month is only 1.9%, and 1 year is 3.5%. New pacemaker implantation is 8.3 at 30 days, and 9.9% at 1 year. Paravalvular leakage is quite low. Moderate PVL at 1 year is only 3.4%. Compared to other valves, ACURATE valve have lower rate of PPM. And also the stroke rate also, around 1 to 3% only, depend on the risk of the patient. So I will share some of our center case. The first case is a 69-year-old female. Risk factor is diabetes, hypertension, dyslipidemia, COPD. The patient is a little bit young. She presented with heart failure, New York Heart Class 2 to 3. Echo ejection fraction is 28% with CVAS. Mean gradient is around 42 mm. This is her CT analysis. Perimeter derived diameter is only 20, which is quite small. And LCA height is 8.7, which is also low. But due to the stent body height is narrow, so it's allowed to deploy this valve. I think as anyone, I think everybody know that the low choric height is increase the risk of the choric obstruction, and there are publication on JCC 2018 that show that LCA height, the lower is more dangerous to cause a choric obstruction compared to the RCA, and less than 10 mm increased chance of early and late choric obstruction. So in this case, we choose ACURATE Neo valve size S. There are this retrospective study that compared the outcome of ACURATE Neo and balloon expandable TAVI valve in small aortic annulus. They compare with SAPIEN 3 retrospective 1:1 propensity match multi-center comparison in 5 high-volume centers in Germany, and it found that there are similar rates of moderate PVL, similar valve performance, and numerical lower new permanent pacemaker rate compared to the SAPIEN valve, and lower 30-day and 1-year mean transvalvular gradient in ACURATE Neo valve. And this case also have a small common iliac artery. So for Boston company, they also provide a lot of accessory device to perform TAVI. So in this case, we choose to use a 14 French eye sleeve, Vascular Access. This 14 French eye sleeve after the device put inside, it will be tracked into trifold expansion. So the caliber of the iliac artery is just only 5.5 millimeter is allowed to use this sheet. So after put the device in the sheet, will extract into trifold. And also they provide the safety guide wire. So this is #1 TAVI wire in Europe. So after I put the eye sleeve sheet in and use a Safari size XS pedalate with 1840 Numet balloon, ACURATE Neo valve size S was deployed. And after that, no sign of coronary obstruction, no immediate aortic regurgitation. Okay. For 18 months, patient clinical symptom improved a lot, and mean pressure gradient decreased to 8 mm, no paravalvular leakage. Okay, the second case is a 75 years old female. Risk factor is diabetes, hypertension, dyslipidemia, and also performed PCI to the RCA and LAD before. She first presented with chest pain and heart failure and have a diagnosis of severe aortic stenosis. This case have a radialized around 22.9 and the LCA high is 8.1. So LCA high is 8.1 and also have a low caliber of the common iliac artery and external iliac artery again. So on the right side is only 5.9, so and the left side is 6. So we use a eye sleeve sheet again on the left side and use a Safari size S pedalate with a 2240 Numet balloon and use the ACURATE Neo valve size. Sorry, this case I use a valve size M. No sign of coronary obstruction, but still moderate AR after first deployment. So we begin to use a post-dilate with 2240 Numet balloon. No sign of coronary obstruction with some mild AR. After 3 months, unfortunately, she developed non-STEMI. Echo show good TAVI valve function with mild AR. Ejection fraction is good and mild inferior wall hypokinesia. At that time, patient denied to do angiogram again. This case, she have some bad feeling about perform PCI because at the second time when I performed PCI to her RCA, my fellow punctured lung and she got a huge pseudonism which required surgery and she stayed in hospital for 1 month. So after 4 months, she and her cousin decided to do CG and PCI again. For this valve, it is easy to engage to the left coronary artery. I performed transradial artery or right radial artery. As you can see on the LAD and left circumference is good. But for the RCA, there are stent total occlusion here. CTO in the stent lesiosis this case. So I performed PCI using the CTO guide wire and put other stent at the distal part. And it's because this valve stent height is quite narrow, so it's easy to engage and put the stent in. So this case delay coronary obstruction more than 7 days. I think is because the patient misunderstanding that after perform the TAVI, she stopped stop some of antiplatelet because she afraid that she will got a severe choroid hematoma again. So she stopped antiplatelet for 1 month, and after she come back, we load antiplatelet again. So TAVI in CCIT, we already performed 31 cases. 10 cases is a Sapien and 21 cases is a ACURATE Neo. So baseline characteristic, patient age mean is around 81 years old, and comorbidity is, as say, most of them are have hypertension. One case is a porcelain aorta. Sapien use 10 case, ACURATE Neo is 21 case. In hospital, mortality is 1 due to sepsis, and early mortality is 1 case, late mortality is 2 case. All of them dead from sepsis, pneumonia, and 1 case have got a TIA, but recover in a couple days. So ICU stay is median is only 1 day. Hospital stay median is 7 days. No permanent pacemaker implantation after use this valve, and reintervention to the valve is 0 case. Functional cast improve tremendously, and post-op paravalve is quite low. For the last 21 case of ACURATE Neo, only 1 case that got moderate paravalve leak. So overall mean gradient decrease significantly, and aortic valve area increase significantly. So conclusion, ACURATE Neo in central chest show good immediate result and satisfactory long-term outcome in ACURATE Neo. Paravalve leak decrease significantly as more experience to aggressive post-dilatation. Especially last 1 case, we don't have any PVL, only just trivial PVL. We found only 1 case that has moderate PVL, and no choroid obstruction during the procedure, and no PPM use. We have 1 case that have the stent thrombosis, and it's easy to access choroid after, even though we use valve deploy and I perform transradial. And I feel that it's like the patient don't have a valve deploy before. So because I lack of time to present, so I cut a lot of slides. So thank you for your attention.
Thank you very much for very excellent presentation and also very good result. So, is there any question? So, I would like to ask about the one thing that complication that we would like to have is the choroid obstruction after after TAVI or something. What is the criteria that because I think ACURATE Neo the incident is lower because there is an upper crown that they say that the crypt of the valve that cause less obstruction. So in general, what is the risk factor for the choroid obstruction, and what about the criteria that if we use ACURATE Neo we can lower the risk?
I see. So there are registries in Europe and USA that found that the choroid height is the main predictor of choroid obstruction after TAVI. So the cut point for LCA choroid height is 10 mm. If lower than that, the increase of choroid obstruction. And the second, actually the cell expandable TAVI valve increase the risk of choroid obstruction, but I think it's not this valve because the study before used other cell expandable valve, not ACURATE. And for registry of ACURATE, there are almost 0% choroid obstruction. And the third thing is a valve-in-valve. But I still don't have experience in valve-in-valve procedure before. Yeah.
So the incident compared with native and valve-in-valve, the valve-in-valve is
higher. Yeah.
And what about the choroid access that you have 1 case to access for the choroid? Because I have some discussion about the post-TAVI and we have to do choroid intervention. It said that it's more difficult.
For me, I'm not sure it was my luck or not. It's easy, so I can engage in just 2 minutes at the same as the normal procedure. And actually, for the LCA, I asked my fellow to engage, and for RCA, I help him a little bit, and it can easily engage also. But for the review literature for PCI after TAVI, they tell about the one valve that is difficult to engage the LCA. It need to decrease the guiding catheter around 0.5. Like when you use normally JL4, we should decrease to JL 3.5.
Okay.
But not this valve.
So maybe I come back to for the first presentation to ask Dr. Chan. And from the registry for the Sentinel that they still have some stroke in case that they use Sentinel is about 5.6%, something like that. So I would like to know the mechanism, or is that because of that we did not protect the left subclavian artery, or is it posterior circulation infarction? Or?
Yes, good question. So I think for TAVI, there's still like about 5% of the chance the stroke is some other else. And also, if you see the curve, you have the highest chance to have stroke in the first 3 days. But still, there are some patients at the back coming out. I think this patient, like they have AF, they are vascular path, so they are higher chance to have other type of stroke. Okay, and I am not sure how much contribution of the left cerebral artery, because if we do the aortic surgery, well, personally, I do this antegrade cerebral protection. I just skip the third one. Usually, I just do 2 cerebral protection. So I will skip the left subclavian artery. So in this idea, the same idea, I don't protect the left vertebral artery. And well, to my experience so far, we didn't have a significant stroke in that area in particular, in the left cerebellum area, something like that. So every patient, I think, is difficult to see how much that particular vessel contribute to the brain supply. So I think we still have a lot of a missing gap in this area, the cerebral protection. But I think there is a need in that. And at least we try to do something the best we have right now. So that's the idea. So I think this is the same way I talk to the patient. Before using the Sentinel device, I would tell them, wow, I will drop down about 70% chance of a stroke, but you still have a chance of a stroke.
Yeah, thank you. Any questions? So maybe because of time, so I would like to ask the last question for both of you. So what is about your idea about the TAVI in low-risk patients in your center, and what about the idea?
Our center is easy, so my recommendation is age only. Any patient 75 years above, no matter the risk factors, if they interest in TAVI, I will offer TAVI. But low risk doesn't mean young. So any patients younger than 75, I will be very, very careful and to discuss in very, very detail, because I still believe in young patients, our surgical AVR is better.
I also agree. I think the age is the most important. If we perform the low-risk patient around 50 years old and he need to perform TAVI again at 60 or 20 years old, is more difficult. And the second thing, I'm not sure that when they have a medial infarction and go to other hospital, other interventional cardiologists can engage the LCA or have some tip and trick to help patient or not. So, and the last thing that I concern that we're still not sure about the valve function in the long term, such as more than 10 years or 20 years. If the valve function is good as the surgical AVR, maybe it can replace the surgical AVR. So the age is the key.
Okay, thank you very much. So because of the time, so I would like to close this section. Thank you very much.
What, HDMI? Or you have adapter?